This episode of The Benefit Whisperer is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget.
And welcome back to the podcast, The Benefit Whisperer, with Ralph Weber. Ralph, how are you?
Bill, I am great. Thank you. How about you? How have you been doing?
I'm good. I mean, we are in the middle of a series, which I find it really fascinating, and that is a history of the healthcare in America over the last 100 years. We've done 2 episodes so far. This episode promises to be compelling because, Ralph, I don't know if you can live up to your promises or not, but you have teased that this episode is about where the money really goes. Because I think most people thought, well, it goes to the doctors and nurses and to the hospital. But apparently that may not be true. We're going to find out in this episode. For those of you who are new to this, who just stumbled across the podcast, by the way, you can go back and listen to part 1 and part 2, and you may want to do that, but don't leave this one because you can listen to this one first and then go back and get yourself caught up. Ralph, this is, it's fascinating and it's full of a lot of things that I think a lot of people don't know about the way the healthcare industry works in this country.
I've told you many times, we've talked about when I used to be an air traffic controller and commercial pilot and how those skills allow me to kind of see in 3 dimensions. Okay. So I can visualize these things. And whenever I travel with my family and something happens, I know what's happening because I've been on both sides of the equation. So my wife always says, is everything okay? Is it? Oh, yeah, it's routine. And I'm looking out the window and saying, I hope she doesn't look out the window and see the engine on fire. So anyway, knowing too much is where I'm getting at. Like sometimes I think I know too much about healthcare because I understand the players, and that's usually important, but you're handicapped if you don't. We all need an advocate to make sure that what should be covered is, and that necessary, needed, life-saving care is not denied by bureaucrats. That's hugely important. People generally think that insurance companies have an incentive to pay less. Well, that's not completely true. Number one, they make a margin on everything. And then there are so many missing pieces. We're going to touch on a few of those where the leakage happens because there's a ton of leakage. So last session, we talked a little bit about when prices broke. Yeah. Okay. Healthcare pricing stopped functioning like real prices. Chargemaster replaced price lists, discounts replaced markets, and allowables replaced transparency.
No, I like the way you use the word transparency because there is a problem with transparency, which is a nicer way to put it than what it's set in my mind. Because in my mind, I think the whole pricing mechanism has become perverted.
Oh, yeah.
It's just it's a mess.
Yeah.
If you have not heard that episode, listeners, go back and listen to that one because it's enlightening.
Right. And of course, the insurance companies and TPAs, third-party administrators, will sometimes fight with an employer in terms of giving them the data. Okay. And I had Chris Condalucci on a prior episode talking about who owns the data. When prices are negotiable after the fact, okay, billing and reconciliation is unavoidable. Knowing your data, knowing what's actually paid is important. Reviewing the contract is hugely important. It can save tons of money. Chris Deacon was on a previous episode, and she saved the state of New Jersey $2 billion over a few years just through the contract wording on their drug spend, their PBM contract. So contract wording is a big part of it.
Wow. Well, I will tell you also, and this is tease for what we want to talk about, but it's also a good reason to go back and listen to episode 2 as well. One of the things that you mentioned in that last episode was the administrative explosion that has happened, where the number of administrators and the cost of administration have blown away the growth in terms of doctors and medical professionals. So what does the data show us? Let's go over that again.
Okay, so I've had several people. I've had a lot of different, very, very good guests. I mean, like everyone has been great. So economists and physicians, both agree that healthcare is expensive, but treating doctors generally are disconnected from the price. They really don't know. Sometimes they even believe that the charge master is the price. So they have been removed because they're just instruments of revenue. The whole RVU, and we'll talk about that, at a certain point in time. I spoke about David Himmelstein and Steffi Wohlhandler. They documented a profound shift as some of these regulations passed, HIPAA, ERISA, et cetera. And, I talked about how in 1970, the number of physicians almost tripled from 1970 to 2020. We're talking almost 50 years, like 43, 44 years. However, healthcare administrators increased almost 50-fold in that same time. The growth of that, it didn't track advances in medical science, which one would expect. It tracked billing complexity. And there were multi-payer because there are all these different insurance companies. There's Medicare, there's Medicaid, there's the VA, there's cash pay, like all of these prices, payers, the complexity, the multi-payer rules, the prior authorization, the utilization management and compliance requirements expanded, and every single one of these scaled the administration layer much farther than the care itself. And remember, Bill, in episode 1, we talked about the definition of healthcare. A lot of people now, when they use the word healthcare, they kind of mean the health insurance. And I even hate to call it insurance because it really isn't, but they talk about the coverage of medical care. Medical care is actually what you get when you go to see a doctor. Let's start with that in terms of, the data on administration.
Okay.
But there's more.
Well, if anybody's listened to any of the Benefit Whisperer at any length, they know that there's a lot more, and it's pretty incredible.
Yeah.
But, I suspect that probably we could get a sense of this administrative cost by taking a look at what happens when I go to the doctor and the doctor says, this is going to be the cost of here's your bill, as it were. How much of that bill actually paid for, my time with the doctor versus everything else involved?
Right. Well, I think there is a huge range. Okay. So, last episode, I talked about a study. It was done by Kevin Schulman and Robert Kaplan and others. Okay. Stanford, Harvard, physician, economist. They looked at the steps, and there are 43 steps, which I'll get into in a second.
Wow.
Basically what happens because of all this added complexity, a single bill, just one medical bill, and we're talking about the life of Bill, not the life of Brian, which was that episode from Monty Python.
The life of Brian was funny. The life of a medical bill is not funny.
No. It would not. Yeah. I mean, it's ridiculous. A comedian could really do some work on it. It passes through so many non-clinical steps, eligibility checks, registration, coding, claim submission, audits, denials, appeals, patient billing, collections, write-offs. So each step exists because the prices and the payment responsibilities are uncertain. Nobody knows who's going to pay what. And the hospitals have evolved, and I'm going to say this and then I'll jump into it later. Revenue cycle management. They have to manage the revenue cycle. Well, that's another thing that has evolved because of this complexity. So, none of these steps improves care. They just add cost.
Well, it's funny. You took that thought right out of my mind. I'm sitting here thinking, these are all cost. These are not things that improve our actual care when we go to the
No,
doctor.
no, exactly.
So what about the whole idea of insurance and billing and everything? A lot of people, I think, would say that they hear a lot about fraud and that maybe fraud is the reason things cost so much. I don't get that sense from what you're saying.
There, that's probably a part of it. I mean, I'm
Yeah,
sure
there
it's
is
a part
fraud.
of it.
Nobody
There
hears,
is.
nobody's here saying there's no fraud in the system.
Yeah. But really, a lot of the leakage, of the money is just because of this complexity. As I said, we spend, estimates are $1.7 trillion a year on administration, something that doesn't add value to the patients. And in 1929, that would have been a lot of chickens.
Yeah.
That would have been a lot of chickens and goats and
For
eggs
those of
to
you
pay
who are
for
wondering
that.
what in the world Ralph is talking about, go back to listen to episode 1. But really briefly,
Exactly.
at
Yeah.
one point back in the 20s, there were
Mhm.
people who bartered for their health care,
Yeah.
and they did it
Yeah.
by, whatever they had in the way of barter,
Right.
whether it was
Mhm.
whether it was
Yep.
cattle or chickens or eggs or what have you.
Yeah. Yeah, exactly. But they knew the prices up front. They knew what they were gonna pay. Now they don't. So these studies that I talked about, the life of a bill, and there was another very, very good one, I think it was also 2018, BIR, okay, billing and insurance related costs, okay?
Mm,
Again, it was Kaplan and Schulman that did this from Harvard and Stanford,
okay.
and they showed how hundreds of billions of dollars, and that was 2018 when it was just hundreds of billions. Okay.
Just
Um,
hundreds of billions.
yeah, I mean, they're spent on billing and insurance related activities. Okay. So, again, I think, you touched on the fraud. A lot of the friction, and friction costs money, is, it's what's driving these costs. It's not as much the fraud, but it's the friction. So, 1.7 trillion out of 5 trillion is about a third, right? But on some bills or procedures, it could easily be 50, 60%. If you're lucky, it might be as low as 15%, but I really don't think that there's a whole lot that's lower unless you pay cash at the time of service. The study that they did, it was published in the JAMA study. Okay. And it was called Administrative Costs Associated with Physician Billing and Insurance Related Activities. Okay. TDABC. Okay. So what it showed is that it takes between 13 and 100 minutes of administrative processing per encounter, depending on the type of service. From primary care to complicated surgery, to cancer, et cetera. So this is it's waste. It is waste. And there's a whole map, a flow chart that shows all of these steps. And that's when, if you ask in advance, like, how much is it going to cost? We don't know. We really don't know. And, I talked about, and I'll touch on this later. I talked about, what does a hospital actually collect? So, make sure you get me to explain that, because it's complicated.
Everything about this topic is complicated.
Yeah.
Okay. And I appreciate you trying to keep it sort of simple, so that it's understandable and maybe leads to some better questions on behalf of people. But when you talk about friction, anybody who knows anything about, mechanical engineering, and you don't have to be a brilliant person to understand mechanical engineering, guys who go out and work on their cars or anything, you understand friction is a problem. Less friction, things more efficient, they move quicker, they move better. And I assume that, like, part of all of what you're talking about here has stuff to do with, like, correct me if I'm wrong, HIPAA, compliance infrastructure, like all of the compliance issues. And I don't know, does the ACA, the American Care Act, fit in here somewhere?
Yes. Yeah. I mean, all of and we touched very, very briefly in episode 1 about a lot of the things that have had impact. We talked about, and I won't recap the ones that we've already covered in detail, but HIPAA.
But they're there, people. Go back and listen to those prior episodes.
Yeah, HIPAA, ERISA, the Affordable Care Act, the CAA, Consolidated Appropriations Act. Each one of these things adds complexity. Okay. And complexity means cost. So HIPAA, required a standardized electronic transactions. Okay. And, it was supposed to sort of strengthen privacy, but it also required extensive compliance, and it really didn't. At the end of the day, it really didn't strengthen privacy. It was supposed to. It made things more complex. It added extra steps. The ACA, the Affordable Care Act, it expanded coverage, standardized benefit, and it also introduced, and I've talked about this before, the medical loss ratio. Okay. And what the medical loss ratio said is that for a fully insured plan, if you're an individual or a company with fewer than 50 people, the insurance company is allowed to spend 20% of the total premium on administration, overhead, taxes, marketing, everything. Okay, 20%. And then for more than 50, it's 15. So let me make an example of that. So let's say an insurance company has a plan that costs $500 a month. Okay, 20% of that is 100. If they said, how can we make this plan cost less? Let's have a narrow network. Let's have a higher deductible, higher copays, higher coinsurance, more pre-authorization, et cetera, et cetera. Let's do everything we can in regards to cost containment to make it cost less. Let's say they drove the price down to half of that, $250. Now, let me ask you a question. 20% of 500 is $100 a month. Do you think it would only cost $50 to administer this lower cost plan? No, it would cost at least 100, even more, because there are more complexities. So the medical loss ratio actually was one of the things that one of the many things that made prices go up. So at first it sounded good. It said insurance companies had to pay, 80% to 85% on medical care. But in reality, that's not what it did. All of these things, number one, we used to have I don't know how many, we used to have a lot of insurance companies that offered health insurance prior to the ACA. After it, really, for the most part, only 5 major big ones: Blue Cross, United Healthcare, Cigna, Aetna, Humana, often referred to as the BUCAs, BUCAH. Those are just initials. So
the BUCAs.
Yeah,
I don't know what a BUCA is, but it sounds good. I like that. Who's a BUCA?
Yeah, so it forced consolidation, pretty much. Really, what do you call them? Monopolies, reduced competition.
Might do that.
Yeah, and they had to be bigger to manage regulatory compliance.
Interesting. Well, we should also. I'm going to throw this in here, and it's an opportunity for another podcast episode. But the ACA, people, I want to remind everybody, was written by insurance companies. So I don't suppose there's anything like a coincidence here, Ralph.
No. Yeah, and then the way it was passed, it had to be rushed through really quickly. So they didn't have a chance. I mean, not that they would have, but it was written by special interest groups. It's really obvious that it was.
And thus the infamous quote from then House Speaker Nancy Pelosi, "We have to pass it to see what's in it," which is one of the most absurd political statements I've ever heard in my entire lifetime, which is crazy. And I don't care which side of the political aisle you fall on. That's it.
Yeah,
that's just
I would kind of expect a doctor to say that, like a proctologist, but I don't know.
Anyway, I don't know. So where do things like, and I'm skimming through this, and I apologize. I'm skimming through this because I want to I want everybody to have just a general sense of things, and hopefully what we do is create enough of an interest that people start exploring these issues and start taking a look at them. Where do things like the PBMs, the pharmacy benefit managers, and other entities come in?
Right. Okay. And that's a great question. I've done a lot of episodes on PBMs, and that alone could be a whole 52 episodes. Okay. So the PPOs were originally supposed to offer group negotiating power, group discounts, et cetera. They did, but discounts off of fake prices, right? PBMs were initially supposed to provide group purchasing powers, et cetera, et cetera. And they looked at the PPO model over there and they said, hey, that's kind of cool. Like that's kind of, like Vegas type magic, right?
Yeah.
We love it. That's great. Let's try to make it even more complex. Okay. Now, drug spending as a percentage of the total. Okay. Remember Blue Cross in 29, Blue Shield in 9. Those were, one was a payment mechanism for hospitals, one for physicians. There was no payment mechanism for drugs. And prior to the ACA, that was almost a separate coverage area. You could actually get a plan without drug coverage at one time. I remember the days. Of course, I remember turning on my high beams with my left foot, but
right. Yes, ladies and gentlemen, he's an antique.
Yeah. So the PBMs, wow. There's so many prices. There's the average wholesale price. There's the acquisition cost. There's so many different prices, so many different layers. There's spread pricing. There's rebates. So what the PBMs did is, number one, the PBM as a separate profit center was not bound by the medical loss ratio rules. So they could make more profit. Okay. Now, the introduced rebates. Okay. If you get this certain drug for $100,000, there's going to be a rebate. Could be 20,000, 50,000, 75,000. So it's a certain percentage. And there are group organizations that manage those rebates. But as Mark Cuban often says, these rebates are the whole reason that your sick employees are paying for your healthy employees, okay, because of the rebates. And, and he's right. He's absolutely right on these. It really masks the true cost. And then there's spread pricing.
Mask. I love that word mask because, again, we're getting to another point that should be really clear here, and it's worth repeating and worth emphasizing. The process mask cost. It obscures true cost. And if you are on episode 3 and you've heard 1 and 2, you know that this is not a debatable opinion. It's just a fact. The process is designed to obscure cost. It is designed to decrease transparency of cost.
Yep. And what they do is they remove transparency, and then companies are developed that says, hey, for so many dollars, we're going to give you transparency. It's kind of like, you give it, you take it away, and then you sell it back. It should have been there, from the start. So anyway, it's crazy. So, again, we talked about the rebates, the spread pricing, vertical integration. Now, I'm not 100% sure that memory serves me correct on these numbers, but I think it was 2018, and don't quote me on these numbers, but I'm going to put them out there with a disclaimer that I'm not absolutely, but they're pretty close to this. Cigna, I think their profits were $48 billion a year, and they purchase Express Scripts for $67 billion. And the year after 2019, all of a sudden their profits were $153 billion. Okay. So boom, 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 right? They jumped up. And in the show notes, if I'm wrong, I'm going to correct those numbers because I'm going to actually look them up.
Check the show notes.
For
the final resolution of that. Absolutely. Yeah. Well, that's amazing.
Yeah. So, another place to make tons of money based on, what's the word I'm looking for, Bill? I was going to use a strong one. Let's
go with
keep
opportunity.
It family friendly.
Ralph, this is an interesting, and you need to answer this. I'm not asking this knowing the answer to it. It strikes me that with the rise of all the Medicare Advantage programs that I see advertised all of the time, that also, those Advantage plans represent opportunities, because we're going to stay with that nice word.
Yeah.
They create opportunities. To what degree do all these Advantage programs represent a problem? I guess I'll be the right one to use.
Well, Medicare was originally composed of Part A, which paid for hospitalization, and Part B that paid for doctors. Then they introduced Part D, which paid for the drugs under George Bush #2. Then, I don't know at what time, but Medicare Advantage was introduced, and it was actually technically Part C. Okay.
Yeah.
So in 2026, Part A is free if you're 65 or older. Okay. Let's just call it that. And what I mean by free is you are no more out of pocket if you enroll versus if you don't.
Right.
Okay. So Part A is, let's use that word, free. Part
And you do,
B.
I'm just going to interject this in here because I want people to understand this. When you turn 65 in the United States, you are required to sign up for Part A. There isn't an option. You have to sign up for Part A, or you'll face massive penalties, by the way.
Well, you actually can opt out. I have seen people that have opted out. I don't know why you would, but it's actually possible. And yeah, but you're right. Huge penalties, and if you don't have creditable coverage every year you wait, there are penalties that are for lifetime. So Part C, also known as Medicare Advantage, number one, Part B in 2026 costs, how much is it? I think it's $202.90 a month, if I'm not mistaken. Okay, that's without the penalties. And then Part D is kind of income tested. It can range between 25 and 75. So Part C came along and it was managed by the big insurance companies.
Yeah.
Okay. And what they said is, hey, look, we're more efficient than government. We're private industry. We're going to manage this whole thing. And as long as you buy Part A and Part B, which is that, $202 a month, as long as you buy those two, Medicare Advantage is free. Okay. And we're going to add drug coverage, and we're going to add dental coverage and, gym membership and stuff like that. Okay. So you do get more benefits. No question. You do get more benefits for that. However, really, they had to risk adjust. They had to basically, what it did is it created an incentive for really aggressive diagnostic coding. There actually is evidence that suggests that billions in overpayments are made versus traditional Medicare. So and maybe that's why they can do it for free. And I'm not bashing Medicare Advantage. I'm just saying that it does provide more benefits. But, again, everything shifts a cost. Like a balloon, you squeeze it in one area, bulges out somewhere else.
No, it is like the old saw. There's nothing ever free.
Yep.
There is nothing that's ever free.
Yep.
Okay. So, I mean, it's just worth keeping in mind. We're running out of time on this particular episode. So let's get to a bottom line here of outcome versus spending.
Yep. Okay. So in the United States, I've talked about that $5.1 trillion. We spend roughly twice as much per capita on healthcare as other developed nations. But, we perform worse based on outcomes like life expectancy, preventable mortality, financial protection. I've talked about that a ton also.
Yeah.
And what I mean by that is protection from bankruptcy, because every minute in the US, a family declares bankruptcy due to medical debt. Every minute. I mean, that's crazy. So a lot of people put off needed medical care because, number one, they don't know the cost and they're afraid of what it might be. So if I don't know the cost and I'm just going to put it off, I'm going to cut my pills in half. So these financial distress, they're one of the symptoms of interacting with the system. I told you earlier, the hospitals had to create these revenue cycle management departments, adding more administration. What they actually get, and I touched on this, and I'm going to go a tiny little bit deeper. The allowable charge is what they are supposed to be paid. There's something called the RAND study that estimates that allowable charges represent roughly 254% of Medicare. Okay, that's an average. Okay. Now, what they actually get, and I'm just going to do a teaser here, is not necessarily the 100% of the allowable amount, because there is friction and drainage and leakage, from what they're allowed to get versus what they actually do. So we'll just jump in there really quick and get back to that on another episode.
Yeah. What it comes down to is something that is really simple and easy to understand. Complexity has increased our costs, and it has not created value. Right, Ralph?
Yes, absolutely right. Yep.
And with increased cost the increased cost translates into opportunity, also known as more profits.
Right.
Which is why so many people, and I'll let you just take a little editorial run here for a second.
Sure.
Which is why so many people find health insurance so aggravating, so frustrating, and why so many people are angry at the insurance industry.
A lot of people are mad as hell, Bill, and they're not going to take it anymore.
Right.
Do you remember that old movie?
I do.
Yeah.
I do. Yes.
That was great. Yeah, with Faye Dunaway.
Yep.
So anyway, next episode, Bill, what we're going to talk about that's episode 4. Might be the last one. There might be a 5. We'll have to see. So we're going to talk about escape hatches, what actually works and how we might actually rebuild healthcare finance around real prices and real value. How about that, Bill? How's that sound?
That would be nice. That would be really, really nice. I suspect it would end up costing us less. We would, and we would get better value or also known as better results. That's great. So for those of you who are not subscribers, hit that follow button right now and become a subscriber, because when you do that, you're automatically notified of when a new episode drops. I would also encourage you to go back and listen to the prior episodes on this particular series, which is the history of healthcare in the United States over the last 100 years. There are many, many, many more episodes for you to explore. So please do explore those. Ralph has referenced a few of those over the course of what we've been talking about just today. Go back and give those a listen. You might learn something, and you might find it really, really interesting. And you might even be, if you're a company trying to manage your healthcare costs, you might think, hey, I should give this guy Ralph a call, because this is what Ralph does.
Yes.
As a matter of fact, he sits down with companies and he helps them manage healthcare costs, and not only manage them, but cut them.
Yeah.
Right, Ralph?
Yeah, absolutely. Most clients, and the first year we could almost guarantee 10% savings just by really analyzing it. But I also do, I'll do an overview, keep doing what you're doing, but let me have a look, and then I will tell you if we can save you or not.
So how do they get a hold of you? That's a pretty compelling reason to reach out to you, Ralph.
They can email me, Ralph, RALPH, at thebenefitwhisperer.com. They can call me at 832-92-fixmybenefitsnow.com.
Yeah, and if you were listening to that and thinking you're in a little bit of a panic because maybe you're in the car or you're doing something else and couldn't write it down, don't worry. It's in the show notes. So when you're done listening, you can just click on the information below and it'll open up and tell you all of that information's there for you.
Right. Yep.
In essence, written down. And if actually Ralph mentioned that if his numbers a little bit earlier where he was relying on his memory, he's going to confirm those or correct those in the show notes as well. So that will be there.
Yep.
So until next time, I'm Bill Tucker on behalf of Ralph and everybody behind the Benefit Whisperers podcast. Thank you for taking the time to listen.
And thanks, Bill.
We'll catch you next time.
Great seeing you again.
Good to see you as well.
Yeah. Okay.